can see that joint. If you're opening your mouth like you're chewing, you can actually feel that joint moving between just below your ear, your ear, whichever you decide, you can feel. So usually when you're opening and closing the mouth, it is the lower jaw that you are moving because there is that joint, temporomandibular joint. And then you can see the parietal bone, which are also two. We have one on this side and there on the other side. And between the parietal bone and the frontal bone, we have a coronal suture. And that is the one that we use to talk about that coronal plane, where you're cutting from maybe anterior to posterior or posterior to anterior. That is coronal suture, coronal planes. So there's a coronal suture. You can see there are many sutures, but the main one that we look at most of the time when you're talking about the planes, we use the coronal plane. And then between the two parietal bone, we have a midline suture. Basically, those sutures are joints, fibrous joints. So we have a sagittal suture, which that is the one that we use to talk about the sagittal planes. We are cutting from either from the midline going to the right or to the left. Yeah, and then you can see we have one occipital bone, that is posteriorly. We have one occipital bone. Of course, we have many, many small bones on the face, around the orbit and so on. We have bones that form the nasal cavity there. Yeah, so, and of course, for a child, you know that there is what we call fontanelles. That is between, for example, the frontal bone and the parietal bone, we have a fontanelle. We have anterior fontanelle. And of course, if you look at a small child, because those sutures will not have closed, there usually will be a pulsating area up there at the frontal part between the parietal bone and the frontal bone. That is called frontal anterior fontanelle. There is a posterior fontanelle, which usually is much smaller between the parietal bones and the occipital bone. Yeah, so in a child, you will have those fontanelles not yet closed. Another thing that we need to note, clinically speaking, is that behind or in the interior part of the temporal bone is an artery that supplies the meninges, called the middle meningeal artery. It's a very important one that if you were to fracture the temporal bone, then you are likely to injure that artery, and there's likely to be a lot of bleeding internally. That is between the skull bone and the meninges. So you have what we call epidural hematoma or extradural hematoma. That is, hematoma is a clot. So if you are bleeding of those arteries, and it can cause a lot of problem, can cause a lot of injury to the brain because it will cause pressure. It will cause pressure to the brain. So it's important that we need to realize the importance of temporal bone. And usually it's quite thin, quite a thin bone. So if you are to traumatize that area, the temporal bone, you are likely to fracture it, and you end up with bleeding from the middle meningeal artery. And then, of course, there we have the X-rays. As I said last time, usually for most X-rays, you want to do two views. You can see on the left side of that picture, we have the lateral view. And then on your right hand, you see the anterior view. That is taking an X-ray from the front and then from the lateral side. And of course, you can see the skull bone there. You can see the cervical vertebra, which, as we said last time, we have 7 cervical vertebra. That is the vertebra of the cervical region, the neck region. Of course, you can see the teeth there. You can see the mandible, and you can see even the maxilla. And then from the front, you can see even the orbits, where the orbits will be. You can see the nasal septum, and then you can see the maxillary bone that has the upper teeth. Then you can see the mandible that has the lower teeth. So there are some things that you can see from these plain X-rays, skull X-rays. Nowadays, we rarely do them. If you have somebody who has a head injury who may require an imaging, you would rather usually nowadays we go for a CT scan head. We rarely do skull X-rays nowadays. It has been overtaken by events. I mean, you would rather go for, if you really require to do any imaging for somebody who have had a head injury, then you would rather go for a CT scan head. Of course, we still do the X-rays of the neck, cervical, especially lateral cervical spine in cases of injury. So I told you last time about trauma series, where we do a lateral spine, lateral cervical spine X-ray, then a chest X-ray and a pelvic X-ray as part of evaluation in cases of trauma. So skull X-rays, we rarely do it nowadays. And then there is the scalp. As I said, if you're talking of the head, you have the skin that is covering the head. We call it a scalp because it has many parts. It's not just the skin. The first part, you can use that scalp, SCALP, as an acronym. For S will be the skin. And of course, we know the skin of the scalp, apart from the face and the neck region, is usually covered with hair. So there's a lot of hair in our scalp, in our skin of the head. That is the scalp. And of course, you can imagine if there is a lot of hair, there is always hair follicles. And usually every hair follicle will be supplied by a blood vessel. So usually the scalp is highly vascularized. That is, it has a lot of blood. So that if you are to cut the scalp, if you are to cut somebody in the head, they tend to bleed a lot because there is a lot of blood. Because every hair follicle has a blood supply. And many, at least majority of the people, unless for those people who have already balded, as in they have a bald head, otherwise most people have a lot of hair in their heads. Yeah, of course the ladies probably have more, and their hair will tend to be softer. The men hair tend to be harder, and so on. Yeah, and then of course in the scalp, the C now is the subcutaneous fat. That's subcutaneous fat, or you can say some book talk of connective tissue. And in that connective tissue, there is fat. And that is where mainly you have blood vessels and nerves. That is in the subcutaneous tissue or the connective tissue. That is where you have the nerves. That is where you have the blood vessels. And that is why if you are to cut somebody through the skin all the way to the subcutaneous fat, usually they tend to bleed a lot because those connective tissue tend to hold the blood vessels and prevent them from vasoconstriction. Usually the reaction of blood vessels when they are injured is to vasoconstrict. But in this case, in the connective tissue tend to hold those blood vessels open and prevent them from vasoconstricting. Vasoconstricting is narrowing, usually to stop the bleeding. So in this case, in the injury of a scalp where the skin and the subcutaneous tissue is cut, there's likelihood of there being a lot of bleeding because those blood vessels will be prevented by those connective tissue from closing or from vasoconstricting. And that is why generally there will be a lot of bleeding when you have a head injury or when you are cut. And then after that, and after the subcutaneous tissue, we have the aponeurosis. Yes, what we come down, we call it galea aponeurosis. You can see that word galea, probably named after somebody who first described it. Galea aponeurosis. Basically, it joins between the two muscles. There is the frontalis muscle, that is at the front towards the face, at the face region. And then we have the occipitalis muscle, that is the occipital region. So between them is the aponeurosis. It's a kind of almost like a tendon, something connecting the two. So that is what is called galea aponeurosis. And that is why you are able to maybe, when you move, you can see the face is maybe creasing that is basically the contraction of that frontalis muscle. And so whatever is connecting the two is the galea aponeurosis. So that is the third layer, the aponeurosis. Then below the aponeurosis is a loose connective tissue. And that is why you are able to move. If you are to hold your head, you feel like it can move. So you realize the first three layers, the skin, the subcutaneous tissue, and then the galea are usually connected together. So that is why, so whatever you are moving, the skin is all those three layers are able to move over the pericranium because of the loose connective tissue. I think if you're able to just hold your head and push it, you can feel it moving over the bone. You feel it like it's moving over the bone. It's because the three layers, the skin, the subcutaneous fat or the connective tissue, and the galea, they are connected. They move as one unit. And then so between is the loose connective tissue, just between it. Yes, and that is why generally if you are bleeding, sometimes the bleeding time, because usually you realize that muscle, the frontalis muscle, is connected to the subcutaneous fat. Is not connected to the bone. So usually if you have bleeding and it's usually into the loose connective tissue, it will tend to bleed and accumulate around the eye level. So you end up sometimes having what we call panda eyes or raccoon eyes. I think some of you probably have seen an animal called raccoon. So sometimes when somebody is injured in the head, the blood tend to accumulate around those regions, around the eyes, the orbital region, call it raccoon eyes or panda eyes. Yeah, because of that loose connective tissue. So if the bleeding reaches there, it tends to accumulate along that layer. And then below, and so of course another thing about the subcutaneous, even as I said, that is where the nerves are, that is where the blood vessels are. So if you are to use local anesthesia to try and repair the injury to the scalp, that is where you will inject the local anesthesia, because that is where the nerves are and that is where the blood vessels are. If you want to do local anesthesia to be able to numb that area for the purposes of repairing the scalp. So that is where you will inject the local anesthesia, because that is where the nerves are. That is in the subcutaneous fat. Yeah, and then one of the things about the Galea aponeurosis is that if you have a cut that is going all the way involving that Galea aponeurosis, what will happen is that wound is likely to gape. So it may be a very small wound, but it will gape because you can see the muscle, the frontalis muscle will contract, pulling it away, and then the occipitalis muscle will also contract. So that gap will increase. So usually when you have to repair, then you have to make sure you have to repair all that layer, especially the Galea aponeurosis. Otherwise, you will have a very big gaping wound. Then, of course, after that, we have the pericranium. Pericranium is the periosteum. Periosteum basically is what you will have in any bone. Covering any bone is what we call periosteum. In this case, what is covering the skull bones is called pericranium. And so you have the skull. That is subcutaneous, the skin, subcutaneous fat or connective tissue. We have areola, we have the Galea aponeurosis. Then the L, you have the loose connective tissue. Then the P, we have the pericranium. So those are the layers of the scalp. Yeah, that whatever it is that is covering the skull or the bone, that is the head. And then, of course, we have the bone now, the skull bone itself, where we have what you're talking about, cancerous bone is basically the bone. You realize this bone has three layers. There is the upper part that is compact, then the middle one that is a bit loose. That is where you will find the bone marrow. Then you have the inner table. So the skull bone, we have the outer table, inner table. We have the outer table, the inner table, and then the places, the inside there, the cancellous bone that is occupied mostly by bone marrow. Remember, the skull bone we said is flat bone. So generally it will have, in an adult, it will still have red bone marrow that could be able to still generate red blood cells. Yeah, so and then we have the other, we move on to the next slide, where basically you can be able to see the foramen magnum. Foramen magnum, foramen, there are very many foramen within the skull bone, where mostly it allows blood vessels to get in or nerves to get in or to get out. Remember, there is the cranial nerve. So there are so many foramen. But the big one here is foramen magnum. That's why it's called foramen magnum. And that is where the spinal cord comes out from. Remember, the central nervous system has, we talked last time about the brain and the spinal cord. So where the spinal cord comes out or exits from the skull, the skull cavity, the cavity of the skull comes through the foramen magnum. And then, of course, you have the cervical vertebra. We said there are 7 cervical vertebra, C1 to C7. Of course, we said we have 8 nerves. Yeah. So you can see the C1, C2, and so on. Yeah, and then you can see also there is the hard palate. So if you look at your mouth, the upper part of your mouth, the inside part of your mouth, there is the soft hard palate, is the front part, then the soft palate posteriorly towards the pharynx. And you can see the mastoid process there. You can see the hyoid bone, and you can see where the thyroid cartilage. So below that, below the thyroid cartilage is where you will have the thyroid gland. Yeah, is where you will have the thyroid gland. Thyroid gland is another important gland that, as I said, is an endocrine gland, a very important endocrine gland that produces those hormones. For example, thyroxine, triiodothyronine, T3. So we have T4, which is thyroxine, and triiodothyronine, which is T3. Yeah, and of course, one of the other hormones that control the production of thyroid hormones is the TSH, thyroid stimulating hormone, and that one is produced in the brain, in the pituitary gland. And then, of course, one of the things about thyroid gland, you really have to know about the blood vessels, the arteries, the veins. You can see the supply, the arteries. What supplies it is, for example, the superior thyroid artery, which is from external carotid artery. Remember the carotid artery, there is the common carotid artery that branches into internal carotid artery and then external carotid artery. So the superior thyroid artery is originating from the external carotid artery. Of course, another supply to the blood supply to the thyroid gland is the inferior thyroid artery that you see is originating from thyrocervical trunk, which is branching from subclavian artery. So it's good to follow those arteries all the way back so that you're able to follow them. And then we have the veins. Mostly these veins drain into internal jugular vein. You can see the superior thyroid vein, there is the middle thyroid vein. So that the two that drain to the internal jugular vein. But you see the inferior thyroid veins drain into the brachiocephalic veins. And then from there, of course, it goes to the superior vena cava. So blood supply, the veins, the arteries, and then the innervations of the thyroid gland. So it's a very important gland. Yeah, of course, sometimes it gets diseased and we may have to do surgery. It becomes enlarged sometimes and can cause, you can see what is posterior to it. There is the trachea right there. And so you can imagine if the thyroid gland enlarges so much, it can cause compression to the trachea. And that in itself can lead to difficulty in breathing, among other things. So sometimes we may need to do surgery to remove it, or it is producing excessive hormones. We call it hyperthyroidism, or very low hormones, and so on. So sometimes you may need to do a surgery. We call it thyroidectomy, that is removing thyroid, which you can remove part of it, part of the lobe, it's lobectomy, or you can do total, where you're removing all the gland. And of course, if you remove the entire gland, then you have to supplement because it's producing those important hormones. So you'll have to supplement the hormone that it usually produces. Yeah, so it's situated in the front of the neck, larynx, and trachea. And you can see the level. So at the fifth, sixth, and cervical, that is the neck, and then the first thoracic vertebra. So that is the level at which the thyroid is located. As I said, it's usually highly vascular. You know, all those supplies, and then the anastomose within the thyroid gland. So it's usually has a lot of blood vessels. So even during surgery, you can really have a lot of bleeding. And you can see the weight, roughly, the approximated weight, and it has a capsule that is surrounding it. And we have two lobes. You can see the left, right lobe. Then in between there, we have the isthmus. Then histology, always for histology, it's always good to think about it. So you can see, that is, I'm looking under the microscope, we have the histology there. And in between, you can see those spaces, there is what we call colloid. That is what those epithelial cells produce, called colloid. And that is where, in the colloid is where those hormones are located. And then, of course, these hormones are usually discharged. For endocrine glands, it usually secrete the hormones into blood vessels. And then the blood vessels are able to carry it all over the body. So usually it's composed largely of spherical follicles formed from cuboidal epithelium. So it's mainly from cuboidal epithelium. They secrete and store colloid. So there is that protein substance called colloid. Yeah, so between follicles are parafollicular cells. So there are some cells also between the follicles. We have what we call parafollicular cells, or you can call it C cells. They can be found as one or in groups. And this one usually secrete a hormone we call calcitonin, which is important in control of calcium level within the blood, together with parathyroid hormone. So they deal with calcium metabolism. For example, this one tends to train and decrease the calcium level in blood, whereas parathyroid hormone try to increase the calcium level in the blood. So they work together to control the amount of calcium within the blood. And then, of course, another important thing about the thyroid gland is that posterior to it, so behind them, we have what we call parathyroid glands. Yeah, you can see there are usually 4, and we can see where they are located. Superior parathyroid, then we have inferior parathyroid glands. And of course, those glands can become enlarged. As you can see, abnormally enlarged inferior right parathyroid gland. And this one, as I said, produces parathyroid hormone or parathormone that is important in calcium metabolism. It's able to control. If there is little calcium within the blood, usually there's increased parathyroid production is increased. There is increased production of parathyroid hormone that leads to absorption, for example, of more calcium within the gastrointestinal system. It leads to retention of calcium by the kidneys. Yeah, and also it leads to resorption of bone, because as I said, one of the greatest store of calcium is bone. So an increased amount of parathyroid hormone leads to resorption of bone to try and produce or get calcium, so that you can increase the amount of calcium within the blood. Yeah, so there are 4 glands weighing around 50 grams. 2 of each is embedded in the posterior surface of each lobe of the thyroid gland, surrounded by fine connective tissue capsule that contains spherical cells arranged in column with sinusoid containing blood in between them. As I had already said, they secrete parathyroid hormone, PTH, or you can call it parathormone, which regulate blood calcium levels together with calcitonin. Of course, you can see, as you can see during surgery of parathyroid, when you're removing the thyroid gland, thyroidectomy, you can easily injure these parathyroid glands, or you can easily remove them. And so somebody will end up with hypocalcemia if you are to remove these parathyroid glands. So during surgery, you have to be careful to spare these parathyroid glands, so that you don't remove them or injure them, because somebody will end up with problem with calcium metabolism. Yes, so of course we're starting to think about the blood supply of the face and the head and so on. So one of the blood vessels, or at least for the face and so on, we have one of these called vertebral artery. You should be able to know where it originates from. Yeah, where it originates from. And then, of course, you can see it going through those, there is some foramina at the transverse processes of cervical vertebra that is passes through it. And this is one of the arteries that supplies the brain. So it goes into the brain, and then it's one of the arteries that is part of the supply. There is what we call circle of Willis that we'll come to later on, that actually this contributes to that circle of Willis. Basically, a circular anastomosis of blood vessels within the brain stem that gives supply to the brain. So very important supply. When we talk about the basilar arteries, after the 2 vertebral arteries, the right vertebral artery and the left vertebral artery come together to form the basilar artery. So you can see another supply. You can see where the vertebral artery comes from. At least on the right side, it originates, or it comes out of right subclavian artery, the vertebral artery. And then we have another supply, the common carotid artery that branches you have an external carotid artery that supplies mainly the scalp, the face, and then we have the internal carotid artery that gets into the brain now to form that circle of Willis together with the vertebral artery and supply the brain. So you can see those relations. As I said, for gross anatomy, you also want to think about the relation. We'll not go into all those details of all those muscles, but it's good to know that those muscles, scalene muscles, but more importantly is to realize where the thyroid gland is located. Yeah, and versus the common carotid artery, where it's located. You can see those sternothyroid, it will almost tell you where it's originating from. Sternothyroid will originate from the sternum and goes to, and in fact, in the hyoid bone. That's why it's called sternohyoid muscle. And then we have another one called sternothyroid. So it originates from the sternum and is inserted in the thyroid cartilage. Those muscles in front of the thyroid gland are called strap muscles. Strap is S-T-R-A-P, strap muscles. And of course, when you are doing thyroidectomy, you have to separate in the midline those muscles and be able to separate them so that you can be able to access the thyroid gland. So those are called strap muscles, and among other muscles that are there in the neck. Of course, blood supply, including you have to have veins. Yeah, so some of these veins are draining the brain. Some of them are draining, the scalp, the face, and so on. So you'll be able to look at them and your own time, try to follow them all the way, to the superior vena cava in this case, then go all the way to the heart. There is an X-ray there of the neck. Usually when we do, that's a lateral view. As we said, you should be able to do two views, maybe AP, anteroposterior, and lateral. The one we can see here is anterior. And then ideally for a good lateral cervical spine X-ray or neck X-ray, you want to see you should be able to see all the vertebrae. Here you can see 1, 2, 3, 4, 5, 6. You cannot be able to see the 7 probably, so it's not very adequate, but at least you're able to see most of them. So in cases of injury, one of the things that you need to do, as I talked about trauma series, is lateral cervical spine X-ray. This is the one that we can see here. Yeah, of course, you can see also the mandible there. Probably this person had a feeling of the teeth and so on, or had probably something. You can see something on the teeth there, probably some crown that done some dental procedures on him or her before. You can see the mandible. So that is an X-ray. It will be usually cervical spine X-ray will be common. And sometimes even as I said, the X-ray of the skull, usually it has been overtaken now. We do mostly CT scan if you think there is injury to the brain. Yeah, you can see another MRI. So another test, of course, that we can do to check the neck and even the head and the brain is an MRI. In MRI, you should be able to, mostly you're focusing on the soft tissues. Like in this case, you can see the spinal cord, and you can see the vertebra, the 2nd, 3rd, 4th, 5th, and 6th, so that the one that have been labeled. But you can see the vertebra, you can see the soft tissues surrounding it. So that would be an MRI, magnetic resonance imaging of the cervical spine. And then we look at the pharynx. So pharynx, we have nasopharynx. That is basically on top of nasopharynx is behind the nasal cavity. If you're to go through the nose, directly behind it, we have the nasopharynx. In the mouth, if you're going to go through the mouth, directly behind the mouth, we have the oropharynx. And then below that, we have the hypopharynx, or sometimes they call it laryngopharynx, because there is the larynx. And then more importantly, you can see tonsils. And I know all of us have heard about tonsillitis. Probably some of us have suffered the tonsillitis. Yeah, tonsils basically are part of immune. They are part of immune system of our bodies, just like lymph nodes. And then what we call Walde's ring. They're like it's surrounding the posterior part or the pharynx. You can see, for example, the adenoid. Adenoid is considered a tonsil also. It's considered one of the tonsils. It's called a pharyngeal tonsil, adenoids. And sometimes some of them hypertrophy or they become very big, so that they can end up closing the the nasal cavity, or can make it narrow, or it can even block the eustachian tube. You can see the orifice. The eustachian tube is what connects the pharynx with the inner ear or the middle ear. So we're talking about the middle ear. What connects the middle ear with the pharynx is called the eustachian tube. And you can see the orifice there that connects it to the pharynx. Yeah, so sometimes if you have, and then we have what we call tubal tonsil, just around where the orifice is. And so if it enlarges, it's likely to close or to block that tube. And of course, if that tube is blocked, if that orifice is blocked, then you are likely to have accumulation of fluid within the inner ear, the middle ear. So you can sometimes have what we call otitis media. Yeah, that is infection within the middle ear. Yeah, so and so these are important. Sometimes we do surgeries now, they can get infected because part of it is like they are like guardians, they guard the pharynx to prevent infection from going all the way to the pharynx. So sometimes they can become infected. So we have palatine tonsil, we have pharyngeal tonsil, those are the adenoids. You can have a tubal tonsil, and then we have even one under the tongue we call lingual tonsil. Lingual refers to the tongue, so lingual tonsil. All those form what we call Walde's ring, and they tend to they guard, the behind the backside, posterior side of the mouth before you get into the pharynx. So sometimes they can get infected and so you end up with tonsillitis. Sometimes they can become enlarged. They can become so enlarged. In fact, the more common ones are palatine tonsils that sometimes if you open your mouth, you can actually be able to see them. And sometimes they become enlarged that they actually touch one another. We call them kissing tonsils. They can become so enlarged. And one of the things is it can now cause problem with breathing. Yeah, especially if it is the adenoid that is enlarged. Especially in children, you can actually have a lot of problem if you have enlarged adenoids. They can cause what we call apnea, sleep apnea. So somebody is snoring a lot at night because the tonsils have become enlarged and causing narrowing of the airways. And sometimes they may have to be removed. There's something we call adenotonsillectomy, where you remove the adenoids and tonsil if they are enlarged or they are infected. And then, of course, you can see there the epiglottis. Epiglottis, basically, you can see at the pharynx there, we have two ways. There is the esophagus, and then there is the larynx, that goes to the trachea. And so you can imagine those when you swallow food, the epiglottis is the one that closes the larynx, that now goes to the trachea and prevents food from getting into the trachea. Because if you do that, there is what we call aspiration. You'll get a lot of problem, infection. Usually food are not supposed to get into the trachea. And so when you swallow, the epiglottis usually should close and allow food to get into the esophagus and into the stomach. And usually the epiglottis is made of cartilage. It's a cartilaginous, it's made of cartilage. Yeah, of course, you can see the thyroid gland and so on. So another thing that is very important that we need to look at is teeth. As I say, teeth is not considered bone, or there are special structures. Otherwise, we would have used it last time when we were talking about types of bone. This is not a bone. It's not considered as bone. But bone, of course, they are very important. And these are embedded in the sockets of the mandible and maxilla. And you know where the maxilla is. That is the upper jaw. That's where the bone there would be the maxilla. And then the mandible will be the lower part, the lower jaw. That is where the lower teeth are situated. So in the young, basically when you are born, of course, all of us are born usually without teeth. Yeah, so once you rotate in maternity or in pediatric ward, you should be able to know when do the teeth erupt, which teeth erupt first. For those of you who have had children, mostly is the lower incisor teeth that usually appear first in most children. So usually for a child, you have like 20 temporary teeth, or they can be called deciduous teeth. Some people call it milk teeth. So there are about 20. Usually for children, they don't have premolars. So there are like 20 of them in a child, temporary teeth that finally, of course, fall off to be replaced by permanent teeth. And usually they start erupting at around 6 months. So when the child is around 6 months, they start appearing. The teeth start appearing. And then by around 2 years, all the teeth should be there. All the 20 temporary teeth should be there. And usually from around 6 years to 13 years, usually from 6 years, the permanent teeth start appearing. Basically, the temporary teeth start falling off one after following one another. And all of us have lost teeth as a child, and now you're approaching 6 years, where now the permanent teeth start coming up. So one important thing is that usually these temporary teeth are important. So sometimes people consider it's not important because one of the things that if a child loses these teeth early, whatever that space will be narrowed so that the permanent teeth will not have space to come out. And those are the people who sometimes they end up getting overlapping teeth appearing from inside or outside, because you lose that space. That tooth is supposed to keep the space and also it helps maintain the shape of the jaw and the mouth generally. I'm sure all of us have seen elderly people who have lost almost all their teeth, and you see how their mouth appears. So their face changes. So teeth are important because of the shape of the face and everything. And for the deciduous teeth should be kept as long as possible because it maintains space for the permanent teeth to come in. So even for children, we encourage that you have to brush, you help the children to brush their teeth. Just like the way you bathe a child, you should be able to help them brush their teeth when they are still young. And then they, of course, when they come to the age where they know how to brush their teeth, they should be encouraged. So dental hygiene, so that we don't lose teeth early, because we end up with the shape of the jaw of the face of the child will be different and so on. So, and then the permanent teeth should be completed by around 20 years. Yeah, of course, the last molar, usually we call it wisdom teeth, because we expect that around 20, 21 years, ideally should be quite wise, isn't it? Of course, unfortunately, it's not necessarily true for everyone. So as you grow older, you should become wiser. That is why the last teeth that appears, we call it wisdom teeth. So an adult, of course, as you know, probably you are taught in high school that there is 32 teeth. That is the dental formula. I think you used to do even the dental formula for a dog, for a cat, and in your story. But since, of course, we are focusing on human. So we're talking of 32 teeth, 12 molars, 12 molars, 8 premolars, 4 canines, and 8 incisors. Of course, you have to know that there is the upper jaw, the lower jaw, and each jaw has 2 sides. Yeah, so this is what we have in an adult. So even for you as an adult, we really want to encourage you to make sure you maintain your teeth. You know, some of you, when you get a toothache, caries teeth. Of course, one of the challenges that many people have is caries tooth, where the teeth develop cavities. So many people usually leave it so long that the only thing that can be done is to remove. So you end up losing teeth. So imagine if your teeth are always being removed. By the time you are a certain age, maybe you're 40, you've lost almost all your teeth. What will you eat with? And then, of course, the shape of your jaw is likely to change. So it's good to keep your teeth as much as possible. Of course, oral hygiene, just brushing your teeth regularly. And when you have issues with cavities, go to the dentist. They can feel. There is what we call feeling. There's what we call root canal. There's what we call feeling, to try and preserve teeth. So let us not be in the habit of going and removing teeth. Rather, we should preserve them. And of course, even for the people, the patients you will always deal with, encourage them that teeth should be preserved. Let them go to the dentist, dental checkup regularly. So we have the structure of a tooth. We have the crown, we have the root. Between the root, the crown, and the root, we have a neck. That is the narrowing part between the crown and the root. We have the neck of the tooth. So the crown, mainly there is the enamel. That is the very hard substance, enamel, that sometimes, of course, if you have a eroding of your teeth, can be eroded by certain food and so on. If you eat a lot of sugar, it's likely to create enzymes that are likely to start destroying this enamel. And finally, of course, it destroys also the dentin. Yeah, and then finally you end up, what usually by the time you have pain in the painful tooth, what we call pulpitis. You can see the pulp there. That pulp cavity contains the nerves, contains the blood vessels. So once the cavity reaches there and the nerves are exposed, that is when now you feel pain. So we have what we call pulpitis. That is the pain you feel of a toothache when these nerves are exposed. So we have the crown that is mainly has an enamel and a dentin. And then we have the pulp cavity that has the nerves and the blood vessels. And you can see there is an opening at the root of the tooth. At the tip there, we have a small opening where the nerves come in through and the blood vessels. And then, of course, what is connecting the bone with the tooth at the root is called what is called cementum. It's like a cement that connects, the bone to the tooth cavity. There is that tooth cavity that now connects it to the root of the tooth. We have cementum. And then, of course, in the crown, we have the enamel covering the outside part of it, so that the dentin should not be exposed. Of course, you have the gum. Yeah, so one of the things that is important when you do good dental hygiene, you're able to maintain your gum or gingiva. So sometimes you can have what we call gingivitis, that is inflammation of that gum. Especially in cases of some malnutrition, sometimes where you are not doing good oral hygiene, you can even end up having what we call gum recession. That is basically the root of your tooth start being exposed. And usually that may lead to sensitivity of teeth and so on. And then you can see, of course, those are the lateral canals, the nerves and so on. Though that is the structure of a tooth generally. And of course, we have several teeth. You can see teeth as, especially the canine and incisors, they tend to have one root. But the others, the premolars, molars, tend to have two or even more roots. And then if you look at the neck, we can divide the neck into, we have a posterior triangle, that is the posterior at the back, and then we have the anterior triangle. Maybe not very important for you, and you can see where the brachioplexus is at the root of the neck, is where we have the brachioplexus. You can see the various muscles, trapezius muscles, among others. And of course, the anterior part, the anterior triangle is where, for example, we have the thyroid gland. So we'll not go into so much into those muscles, but it's good to know we have those muscles at the neck, and it's good to know the innervation, for example, of those muscles. For example, the sternocleidomastoid muscle is innervated by, most of these muscles will be innervated by accessory nerve. We have a cranial nerve 11. That is why you are able to shrug your shoulder because of the innervation of these muscles by the accessory. And then, of course, turning your head. When you're turning your head to the left or to the right, it is still that accessory nerve that is acting on these muscles of the neck. The skin, just like the skin of the abdomen, also the skin of the neck. If you look at the anterior part of the neck, when you look at those layers, so we'll have the skin, then we'll have fat. So unlike, of course, you will not call it campus fascia like for the abdomen, but there is the layer of the fat. Then after that, we have what we call platysmus muscle. It's a small muscle, yeah, that actually when you're doing surgery for us, when you're doing, for example, thyroidectomy, and you open the midline of the neck, usually when you're closing it back, you have to ensure that you close this muscle, this platysmus muscle. Otherwise, there will be that, the skin will not be able to close well. You will have atrophy of that skin after you close it because this muscle will pull it apart. And so you will end up with only the skin. So you should be able, this is one of the muscles that you have to repair for you to attain a good repair after an operation on the neck. So platysmus muscle. You can see, of course, there are veins there in the loose connective tissue. And then looking at the brain, yeah, so just a few details. You can see the brain. In this one, you've divided it in a coronal way. This is a coronal plane. This is a diagram of the brain that has been cut in coronal plane, where you can see the cerebrum. The cerebrum is, sometimes we call it neocortex. It's the biggest, it's the largest part of the brain, the cerebrum. And it consists of cerebral hemispheres. You can see there are two, you can see in the midline, there's that sulci there dividing into two. So we have two cerebral hemispheres. And each hemisphere extends from the frontal to the occipital bones. Yeah, it extends from the frontal to the occipital bone. That is, if we are to look at it from the lateral side. So each hemisphere extends from the frontal to the occipital bones. Yeah, and then you look at the surface of the hemispheres, those hemispheres, the surface, the very surface of it we have the cortex, which mainly is made of gray matter. And gray matter mostly is made of mainly the cells. Remember last time we talked about the neurons. We have the cell bodies, and then we have the axons. So mostly the surface of it, of the cerebrum, is made of the cortex, C-O-R-T-E-X, and mainly is the gray matter. And that is where mainly the cell bodies are located. Then the inner part of it mostly is made of the axons. Yeah. And so around there, that is the cerebrum, is where we have, sometimes it's divided into many areas. We have the motor area. We call it precentral gyrus. That is the anterior part of the cerebrum. And then we have the sensory area. That is just after the central sulcus. There's a sulcus, if you were to look at the brain from the lateral side, that divide it so that we have the frontal part of the cerebrum, then we have the parietal part. So we have the sensory area. That is the area mostly that sensation, that is where the sensation is made sense of there. Then we have the auditory area. In the cerebrum, we have an area called auditory area. At the superior temporal gyrus, if you are to look at the picture of a brain, you'll see superior temporal gyrus, and that is where we have the auditory area that deals mainly with hearing. So that is where all the impulses to dealing with hearing will end up in the auditory area at the superior temporal gyrus. Remember the brain, we have, if you look at the brain, it's not smooth all the way. There are some areas that dip in, that are called sulci, and there are areas that are raised, that are called gyri, or one you call it gyrus. So we have an auditory area. Then we have an area called Broca's area. I think it was named after somebody who first described it, called Broca's. Yeah, so that is the area we call motor speech area. So this one mostly deal with the muscles of speech. So it controls the muscle of speech. So you can imagine if you have injury around that area, then you will not be able to speak because it will be affected. So this one controls the movement employed in speech. Those movement employed by speech is controlled at that area called Broca's area, the motor speech area. Yeah, and mostly for most people, this Broca's area or the motor speech area is mostly dominant in the left hemisphere in most right-handed persons. So in most right-handed persons, this one mostly will be in the dominant in the left hemisphere in right-handed people, and in the right hemisphere in left-handed people. So in people who are left-handed, it tends to be more on the right side. That is the Broca's area. But for the most people who are right-handed, tends to be on the left. Then there is the visual area. That is still in the cerebrum. We have a place called the visual area. And this one mostly would be in the posterior pole. That is in the occipital lobe. Yeah, that is the posterior pole and medial aspect of cerebral hemisphere in the region of the calcarine sulcus. So it is the area that receives visual impression. So really our being able to see is because of that temporal lobe, the posterior lobe. That is where the visual area is. So that sometimes you can actually have what we call central blindness. Just because you have a problem or that lobe, that visual lobe is been destroyed. So you end up having a blindness, yet your eyes are actually normal, because all the impression that we get eventually have to end up in that area. So that is the cerebrum, is the largest part of the brain. And it has those two lobes, those hemispheres. Of course, I'm sure all of us have heard about, a famous neurosurgeon, Ben Carson. He was among the first people to be able to remove half of the brain. So they could remove one hemisphere, the entire hemisphere. We call it hemispherectomy. It's rarely done, but he was able to do it, because sometimes you can have epilepsies, for example, that seems to be originating from only one hemisphere. So part of the treatment can sometimes be having to remove the entire hemisphere, part of that hemisphere. So Dr. Ben Carson was one of the first people to be able to pioneer that surgery. It was a dangerous surgery, but I think it's being done more frequently nowadays. And then, of course, we have the thalamus. Yeah, we have what we call diencephalon, which consists of thalamus and hypothalamus. Yeah, and you can see the thalamus there. And then, of course, you can see the pons. Yeah, what we call the brain stem, where we start about the midbrain. Then we have the pons. We have the medulla oblongata. Then after that, from there, it continues on now to the spinal cord. So I think, so cerebellum mostly deals with balance, yeah, and posture. When you talk about cerebellum, it almost suggests that it's a small brain. So as I say, the thalamus and hypothalamus, that is what sometimes we call it diencephalon. It consists of the thalamus and the ventral. Ventrally, that is in front, is the hypothalamus. Yeah, so mainly the thalamus is gray matter on either side of the third ventricle. So on either side of the third ventricle is mainly the relay station on the afferent sensory pathway to the cerebral cortex. That is the thalamus. Then hypothalamus is the lower part on the lateral wall of the floor of the third ventricle. Mostly hypothalamus deals with hormonal control. That is where the pituitary gland will be located. So mostly those ones deal with the control, the hormones control. For example, the thyroid stimulating hormone and other hormones that are produced that are controlling other organs within the body. it is in the hypothalamus. So looking at the fat of the brain, you can divide it into the forebrain, which includes the cerebrum, which I've already mentioned. And then the cerebrum, there are some cavities within the brain. They are what we call ventricles. So in the cerebrum, we have the right and the left ventricle. And with these ventricles usually is the CSF, cerebrospinal fluid. Yeah, they are what we call choroid plexus within the mucosa or the epithelium of this ventricle. There are spaces within the brain. So they are what we call choroid plexus. Those are the ones that produce CSF. Yeah. So in the cerebrum, we have those two ventricles, right and left lateral ventricles. And then in the diencephalon, which I said involve the thalamus, consists of the thalamus and hypothalamus, we have a third ventricle. So we have two ventricles, left and right, and we have the third ventricle. And then you go to the midbrain. As I said, when sometimes some people call it the midbrain and the hindbrain, we call it the brainstem. So some people and some books will talk about the brainstem, which involve the midbrain and the hindbrain. And the hindbrain consists of the pons, medulla oblongata. Mostly those are the time people call it the medulla or medulla. And then we have the cerebellum. Cerebellum also suggests a small brain. And then in the midbrain, we have the cerebral aqueduct. That is what connects the third ventricle and the fourth ventricle. So in the hindbrain, you have the fourth ventricle and then the central canal. The central canal now continues into the spinal cord. Yeah, so in the fourth ventricle, we have the pons, the medulla oblongata, the hindbrain, and then the cerebellum. So looking at the brain, midbrain mainly is a narrow part of the brain that passes through the territorial notch and connects the forebrain to the hindbrain. Yeah. Then we have the hindbrain, which, as I've said, is consists of the pons, medulla, and cerebellum. So looking at the hindbrain or the midbrain, you have the midbrain, for example, situated, as I said, the midbrain is situated around the cerebral aqueduct between the cerebrum above and the pons below. So mainly, if you look at the midbrain, it consists mainly of nuclei and nerve fibers, tracts. So mainly nerve fibers originating from the cortex of the cerebrum, which connect the cerebrum with the lower parts of the brain and the spinal cord. So this nucleus act as relay station for ascending and descending nerve fibers. So there will be nerves, of course, that are coming from the cortex of the cerebrum all the way as it descends all the way to the spinal cord. So it's like a relay station connecting the two. And of course, it has an important function in auditory and visual reflexes. So it has some reflexes. Remember, there's some action that are reflex action. And then, of course, also in the midbrain, we have a pineal body that are attached by a stalk to the region of the posterior wall of the third ventricle. And usually these pineal bodies in elderly, they tend to calcify in the elderly, in the middle age and the elderly. And so sometimes when you do an X-ray or even do a CT scan, you can be able to visualize the pineal bodies. Yeah, or you can call them pineal glands, that they appear because at that age, in the middle age and the elderly, they can calcify. And then talking about the pons, you come down to the hindbrain. We have the pons. These are composed mainly of nerve fibers, which connect the two halves of the cerebellum. So it also contains the ascending and descending fibers connecting the forebrain, the midbrain, and the spinal cord. And some of the nerve cells within the pons serve as relay station, whereas others form cranial nerve nuclei. So some of these also form cranial nerve nuclei. So generally, when you look at the cranial nerve, most of them will originate from the pons, the medulla oblongata, and part of it from the midbrain. That is where most of the cranial nerve will be midbrain, the pons, and the medulla oblongata. So you'll have nuclei of the cranial nerves in the brain stem. That is the midbrain, the hindbrain, where it consists of the pons and the medulla oblongata. So when you look at the medulla oblongata, let me not mention the other one. Let's just call it medulla. Yeah, generally it's conical shape in shape and connects the pons above to the spinal cord below. So it connects the pons above and then the spinal cord below. And then when you look at the pyramids, when you look at those swellings, there's some swellings within the medulla. They are called pyramids. They are mainly bundle of nerve fibers that originate in the large nerve cells in the precentral gyrus of the central cortex. And one thing that you need to note is that most of the descending fibers are cross over to the opposite side, forming decussation of the pyramids. So at that level of the medulla oblongata, the nerves or the tracts that come from the cortex there, they tend to decussate. That is, they cross, so that the ones from the right side, the right hemisphere, goes to the left side. And then the one from the right side goes, the left side goes to the right. And that is why sometimes when somebody has stroke, when somebody has stroke, the stroke is on the right side, but they'll have weakness on the left. And then when it is on the right, the stroke is on the right, they have weakness on the left. When it is on the left, the weakness will be on the right because of that decussation, the crossing over at the medulla. Yeah, that explains how you will have hemiplegia. That is weakness on one side when you have stroke on the opposite side because of that decussation. So it's important to realize there is that decussation. Decussation is D-E-C-U-S-S-A-T-I-O-N. So decussation of those fibers at the medulla. So and then the cerebellum basically lies within the posterior cranial fossa. Remember, if you look at the cranial, the inside part of the skull, the fossa, there's the anterior fossa, there's the middle cranial fossa, then there's the posterior cranial fossa. So the cerebellum lies within the posterior cranial fossa beneath the tentorium cerebelli. So there is those things that separate the brain. There is what we call tentorium cerebelli. When you look of something talking of tentorium, it almost is tent-like. So it separates the cerebrum and the cerebellum. We call it tentorium cerebelli. So it's situated posterior to the pons and the medulla oblongata. So it's posterior to the bone. That is, the cerebellum is posterior to the pons and medulla oblongata. And it consists of two hemispheres, almost the same. That is why it's called cerebellum, small brain, because it's almost the same with the cerebrum. It has also two hemispheres. Yeah, so the surface of each cerebellar hemisphere, the cortex, is composed of gray matter, just like the brain. Remember, we talked about the cerebrum. Also, the cortex of it consists mostly of the gray matter that mainly has the cell bodies. The white matters lie deeply. So the white matters that mainly has the axon lies deeply. So the cerebellum plays an important role in control of muscle tone and the coordination of muscle movement on the same side of the body. So it usually controls movement and even the tone and so on. That is why, for example, if you see somebody who is under who have drank a lot of alcohol, they usually have problem with, they're not steady. They're almost falling over because it tends to affect the cerebellum, and so they are not steady. They are walking in a weird way. They end up falling down and so on. And of course, there are some other drugs also that can affect the cerebellum. And sometimes there are some diseases that tend to affect the cerebellum, especially as you grow older, that end up affecting the movement, fine movement. Yeah, for example, we can end up having things like tremors, hand tremors and so on, because of the cerebellum being affected. One of the things that you need to realize is cerebellar activity is not under voluntary control. So cerebellar activity, the activities of the cerebellum are not under voluntary control. So they're involuntary. So as I've already said, pons processes information from several of the cranial nerves. So it has a lot of cranial nerve originating from there. And so it processes a lot of information from those cranial nerves. So it's good to look at those, have some details, a bit of details about the cerebellum, the encephalon, the midbrain, and we've looked at all the others as well. And then the cranial nerves, I think this one will not spend a lot of time in it. We are hoping Sorry, we began late, so we hope to finish by hopefully 1/2 past or maybe 40 past. So, so we'll just briefly, because we had already looked at the cranial nerves last time. So olfactory, we know that one has to deal with the sense of smell. That is cranial nerve 1. Cranial nerve 2 is the visual, the occipital lobe. It goes to the occipital lobe. That is the visual cortex, because this one is basically to deal with sight. Then oculomotor nerve. So mainly this one supplies most of those extraocular muscles. Extraocular muscles are muscles that mainly are outside on the orbit of the eye that control the eye movement. So if you're looking up, down, so those are the names of some of those muscles: superior rectus, medial rectus, inferior rectus, inferior oblique muscle. Those are the muscles that are supplied by oculomotor nerve. And then we have trochlear nerve that mainly supplies one of those extraocular muscle, which is superior oblique muscle. And this one is purely motor, so movement. Yeah. And then we have trigeminal nerve, cranial nerve 5. Trigeminal refers to, if you have tri, so it's 3. And mostly it's sensory. So we have the ophthalmic part, that is the upper part. We look at the upper part of the face, the maxillary area. Then we have the mandibular area. That is sensory to those areas. But we have also motor, especially to muscles of mastication, of chewing. So, for example, if you chew, you can feel a muscle contracting, the masseter muscle. So that is applied by trigeminal. So it has both sensory and motor. Then cranial nerve 6 is abducens, and this one also supplies its muscles of the extraocular muscle, lateral rectus muscle. So you can imagine from the word lateral, so it tends to, if you're looking at the lateral side, that is the muscle that contracts, enabling you to turn your eye to the lateral side. So lateral rectus muscle. The facial nerve, basically the muscles of facial expression. Yeah, like for example, the frontalis muscle that you can be able to, crease your face and so on, frown and so on because of those facial nerve. But also it has a part in tearing. When you are crying, so it supplies that those tear glands. And also salivation, salivary glands, some salivary glands are innervated by that facial nerve, and also taste, especially the anterior part of the tongue. It's mostly that is where it's concerned with taste, and that is where it's innervated by the facial nerve. Then we have cranial nerve 8, vestibulocochlear. As you can see, the name, it has vestibular part, and then we have the cochlear part. So this one is the one that deals with hearing, the sensory, the auditory, information, processing, to do with balance. Especially we talk about vestibular, you're thinking about balance. So that sometimes when you have ear problem, you actually may have issues with problem of balance. And sometimes you may have some hearing, something called tinnitus, that's abnormal sounds from the ears, if you have problem with this particular nerve. So vestibulocochlear nerve, sensory, so to the hearing and so on, auditory, and also balance, proprioception. And then we have cranial nerve 9, glossopharyngeal. This one deals with taste, especially the posterior part of the tongue. Yeah, that's where it innervates. And then also salivations and salivary glands. And then sensation in the oropharynx. This is the one that you talk about, the gag reflex. One way of testing it is gag reflex. If you put your finger behind your mouth, you are likely to want to form it. That is gag reflex. So that is the glossopharyngeal nerve. Then the vagus nerve that we've talked about a lot, the wandering nerve. So visceral sensation to the brainstem and control some visceral functions such as the heart rate and gastrointestinal motility. So it goes all the way. Yeah, and of course it supplies also around the throat, the airway. Like for example, the vocal cords is supplied by the vagus nerves. Innervate the neck muscles and involve in head turning, and also if you're shrugging your shoulder, that is the nerve that is also still functioning at that point. Yeah, then hypoglossal, this is the nerve, especially motor, the muscles of the tongue. That is why you're able to protrude your tongue, you're able to bring it back, you're able to turn your tongue to one side and the other, is the hypoglossal nerve that supplies there. So that's the cranial nerves. You can see the brain there on the lateral side. I think I've already gone into some details, so I'll not go into a lot of detail. You can see one of the sulci that is dividing a gyri that is separating the brain into the number one. There is the frontal lobe. That is if you're looking at the cerebrum. Then we have the number two is the parietal lobe, and then there we have number four. We have the posterior lobe, and then number three we have the temporal lobe. Yeah, and then we have, you can see where the cerebellum is, and then the pons. Then down there you have the medulla, and then you have the cerebellum. Yeah, then of course one important thing that we always have to note is the blood supply to the brain. And I'd already talked about the circle of Willis, so probably named after somebody who described it. And you can see this circle, and it helps because when you are turning your head sometime and so on, you are able likely to kink one of those arteries. But because there is such circle of Willis, it's able to be supplied round, as in the blood is able to, it's like almost a kind of anastomosis. So you can see the middle cerebral artery. Mainly it comes from the internal. Remember the internal carotid artery, there was the external carotid artery. From the internal carotid artery, once it is inside the brain, you have that branch. You have the anterior cerebral artery. You have the anterior, and then between the two anterior cerebral artery, you have anterior communicating artery. And then of course you have some branches there. And then you have the major branch is the middle cerebral artery. And then of course you have another posterior communicating artery that communicates now with the basilar artery. Remember the basilar artery, as I said, the two vertebral arteries join together before it goes into the skull to form a basilar artery. And you can see the branches of the basilar artery. They are the pontine arteries, that is, those one will supply the pons. You have the superior cerebellar artery, so it will supply the cerebellum, and then you have the posterior cerebral artery. Yeah, so those are some of the branches of the basilar artery. And then of course there is that connection. So that is what becomes now the circle of Willis. And it's helpful, as I said, if you're turning your head and so on, and one of the vessels is kinked, then because of that presence of that circle, the blood is likely to still go around and supply. So it's a kind of protection that God has put in place for us to be able to protect a vital organ like our brain. And then of course we're showing the regions that are supplied, the region of the cerebrum that's applied by the various arteries. You can see the yellow part. So if you are to cut the brain into two, so you can see on that side, on one of half, and you can see the medial part of it, the yellow part, that is where the anterior cerebral artery mostly will supply. And then of course you can see partly anterior part and even the lateral part. So those coloring, the anterior cerebral artery, you can see where it supplies, so that sometimes if you have stroke, for example, sometimes you can have blockage of any one of those arteries. So if you have blockage of the anterior cerebral artery, you can see where the infarction will take place. You can see the type of stroke you are likely to have. That those areas that are supplied by that artery will necrose, will die out. And then you can see the middle cerebral artery, the areas that it supplies, the red areas. This is looking from the lateral side. You can see the areas it supplies. So if you have blockage of middle cerebral artery for whatever reason, maybe narrowing, or there's a blood clot there, or it is cut, then you are likely to have stroke affecting. Basically, stroke is infarction of the brain tissues, most of the time because of maybe blockage of the blood vessels. So you can have one we call infarction, a stroke. You can have infarction or bleeding. You can have hemorrhagic stroke, or you can have ischemic stroke. Ischemic is where blood is not reaching there. Hemorrhagic is where the blood vessel is cut, and so there is bleeding into the brain. And then you can see the posterior cerebral artery mainly supplies the posterior lobe. Yeah. So that is the blood supply. So that it is good to know when you have somebody having stroke in a certain area, and then you have certain symptoms, then you know, for example, maybe which artery may have been affected. And very importantly, also we need to think about ventricles. Yeah, ventricles, as I've already said, are spaces within the brain. Yeah, that is where the cerebrospinal fluid is produced. And cerebrospinal fluid is important because it suspends basically our brain and helps to reduce shock and so on, and also tends to be able to absorb any waste products within the brain, because finally all this cerebrospinal fluid has a circulation with the blood. Yeah, it finally ends up in blood. Yeah, so it has a lot of function, this cerebrospinal fluid. And those, we have these ventricles. So we have the two lateral ventricles within the cerebrum. Then we have the third ventricle, and then we have that aqueduct that connects the third ventricle and the fourth ventricle. Then we have the fourth ventricle. So we have basically 4 ventricles, 2 lateral, that ventricle, and then we have the fourth ventricle. And then from there it continues to the spinal cord in the central canal. Yeah, so the brain, of course, you can have it in, this is a sagittal view. Thing we've talked about, you can see the cerebrum. If you are to cut it, you can see the hypothalamus, you can see the thalamus, you can see the midbrain, the pons, the medulla oblongata, the spinal cord, the cerebellum. You can see the pineal gland, the one that I said in old age, in certain age, in middle age and old age, they tend to calcify. So if you are to do a CT scan, you see them, they appear like bone. Yeah, but it's not bone, it's the calcification. Of course, there are many things that we can investigate the brain with. One of it is an MRI, and you can see an MRI. Mostly, as I said, MRI, mostly you're looking at the soft tissues. Yeah, and so an MRI would probably be a good test when you want to look at the brain itself. But you can still, of course, see and discern the bones. You can see the cerebrum there. You can even see the brainstem, the midbrain, the pons, the medulla. You can see the cerebellum posteriorly. So, and you can see the spinal cord. So there are many things that you can see from an MRI of the brain. Then the CT scan of the brain. So this was lateral view. So these are lateral cuts, or coronal, these are sagittal cuts. And then this one is axial cuts. This is now the CT scan of the brain. And then from this cut, you can see the lateral ventricles. You see anteriorly there, you can see the lateral ventricles. You can see even the third ventricle there in the midline there. You can see the pineal gland. Those two whitish looking, like they almost look the same density with the bone. Those are pineal glands. So you can suggest to you that this, whoever the person from which this scan was taken was in the middle age or old age, because you can see the pineal glands have calcified. So you can see the series. Usually if you are given a CT scan of the head, you'll be given all this. And usually you'll be given 2 views. This one is, you're looking mostly at the bones. So this one is called bone window. And the axial scan cuts. You're cutting it from the neck going up. Those are axial planes. You're cutting it at the axial plane. So this is what we call a bone window. So you're looking with this bone whether there are any fracture. And you can see there's a depressed skull fracture there when you look at the right side of your brain, of that scan. So basically that is the left. Usually when you look at the CT scans like this, the left side will be where the right side will be, and then the other side is left. So you can see he has a depressed skull fracture on the left parietal region. Yeah, and those are axial scans. So another thing you always do is the brain window. That is basically you're looking at the brain in that CT scan. And you can see there's a bit of bleeding around where the depressed skull fracture is. There's a bit of contusion or bleeds there. And you can see the ventricles, the lateral ventricles. Yeah, you can see those dark areas within the brain. So it's filled with CSF. So from the CT scan, you can be able to see, and you should be able to look at the midline. You have to ensure that there is no shift in the midline. You look at the ventricles that are not compressed, because if they are compressed, it will suggest there's probably a space occupying lesion on the opposite side. Another thing that is very important when you look at the brain is the covering, because you need to know that, from the skin, from the scalp, you go to the skull bone. Then as you go inside the brain, there are still some other things that are covering the brain. The way God put it is to really protect, because the brain basically, it has a consistency of almost chocolate. If you are to hold a chocolate and that gel, like, it's very soft. So it has to be protected really. And that is why there's a skull bone. And then after that, there is the meninges. So basically coverings of the brain. And we have 3 meninges. We have the dura mater. Yeah, dura mater. It's the very hard one. Mater almost suggests in some languages mother. So it's the hard mother, the dura. And you talk of dura is something, so it's the dura mater. So we have dura mater. That is the one that is connected to the skull. Yeah. the dura mater. And then next, after dura mater, we have a space between the dura mater and the arachnoid. We call it subdural space. A subdural space between the dura mater, the arachnoid mater, and the dura mater. We call subdural space, a potential space, a small space. And then after that, we have the subarachnoid matter, subarachnoid matter. Now, talking of arachnoid, I'm sure you've heard about it. Arachnoid refers to a spider. So because it has those separation that connects it to the pia mater, so they look like spider's web. That is why they are called arachnoid. So we have arachnoid matter. And below the arachnoid matter, we have subarachnoid space. And usually in that space is filled with CSF, cerebrospinal fluid, is where it is filling that space, subarachnoid space. And then after that, we have the pia mater. The pia mater is firmly attached to the brain. So it will go through all those sulci, where there is a sulci, where there is a gyra, it goes firmly attached, and it is very thin. So the pia mater. Yeah, so we have those three. And you can see those granulation, arachnoid granulation. That is now what connects the subarachnoid space to the sinuses. Sinuses are basically filled with venous. Those are the veins within the brain. They're called sinuses. One of them you can see there is called superior sagittal sinus. So from those granulations, arachnoid granulation, that is where now the CSF is able to communicate and get into the blood, into those sinuses. So they are called arachnoid granulation. Sometimes, of course, with infection, if you have infection, meningitis, for example, meningitis is inflammation of those meninges. You can end up actually having blockage of this arachnoid granulation, and you end up with the buildup of CSF within the brain. You end up with hydrocephalus. So one of the causes of hydrocephalus is meningitis that affect and block these openings within the arachnoid granulation so you end up with increased intracranial pressure. You end up with hydrocephalus. And then, of course, more importantly, the importance of these meninges is one of the things that can happen. You can have bleeding. For example, if you have a skull fracture, I talked earlier about if you have to fracture the temporal bone, you end up with bleeding from that middle meningeal artery. And blood can accumulate between the skull and the epidural space. So you end up with what we call epidural or extradural hematoma. So you end up with a clot accumulating there. And of course, if it accumulates there, it compresses the brain. And so somebody can end up losing consciousness and so on because of that epidural or extradural hematoma. That is accumulation of blood between the epidural, within the epidural space. That is between the skull and the dura mater. And then, of course, you have that subdural space. That is the space between the dura mater and the arachnoid mater. And also, it can bleed. There also, you can have bleeding into that space, especially with the elderly. The veins tend to become loose, and they tend to bleed into that space, subdural space. And so you end up with a hematoma called subdural hematoma. So you can have a lot of bleeding into that subdural space. And of course, it will also compress the brain. And so somebody will end up with loss of consciousness and so on. Of course, surgeries can be done to drain. So when you have blood between the epidurals into the spheroids, you can do surgery. You open that skull, you cut through the skull, and then you evacuate the clot. Even for the subdural space, you can actually open the skull, and then you cut through the dura mater into the subdural space, and then you evacuate the clot. Yeah, so you can have subdural hematoma. And then also it can bleed, somebody can bleed into that subarachnoid space. So you have subarachnoid hemorrhage, bleeding into that subarachnoid. And so you will end up, if you are to remove the CSF, usually CSF should be clear. But if there is subdural bleed, hemorrhage into this space, then if you are to remove the CSF, it will be blood stained. Yeah, so those are mainly the importance about these meninges. Yeah, they can have a lot of bleeding into it. And so we can have a lot of challenges with pressure to the brain, which you may be forced actually to do surgery. Then looking at the spinal cord. Yeah, so spinal cord, I know we mentioned earlier about the spinal cord when we were talking about this nervous system. When you talk of the central nervous system is the brain and then the spinal cord. You can see where the points are, the medulla oblongata, then continuation into the spinal cord. And you can see where the spinal cord ends. So the end of the spinal cord is called conus medullaris. And usually this one ends around the lower part of L1. So lumbar vertebra 1, that is where the spinal cord ends. So below that, we don't have the spinal cord. All we have is nerves, nerve fibers. Yeah, so the spinal cord ends around the lower border of L1, the lumbar vertebra 1. And then from there, we have what we call filum terminale. Filum terminale, basically, as we have said, the pia mater is firmly attached to the surface of the brain and continues all the way even to the spinal cord. So it's firmly attached to the spinal cord. And so when it reaches after the conus medullaris, that is the end of the spinal cord, this filum terminale basically is a continuation of pia mater. And it goes all the way and attaches to the coccyx. It goes all the way and attaches to the coccyx. So that is what we call filum terminale. So vertical, and then there is something called cauda equina. Remember, after the end of the spinal cord at the conus medullaris, all you have after that is nerve fibers. Yeah, because basically nerve fibers from L1, they are long, so they are just hanging like the tail of a horse. Or even you can talk of, if you've never seen a horse, probably a cow is not very far from the tail of a cow or a donkey. So that is what we basically, when we talk of cauda equina, it's a vertical leash of nerves around the filum terminale. They look like the tail of a horse. So equina refers to the horse, and then the cauda is the tail. So cauda equina, so it looks like the tail of a horse. So go look at the tail of a horse. So that is how those, because you are basically seeing those nerves. Yeah, because the spinal cord has ended. So lower nerve roots together, so they go together from the lumbar region and so on. So called cauda equina. Again, a diagram showing the conus medullaris, that is the end of. So as I said, the spinal cord ends at around L1. And so you can see up or beyond there, that's what we call lumbar cistern, because this is still this arachnoid space. So just above it, we have the subarachnoid or arachnoid matter. And in between here, there will be now subarachnoid space. And as we are saying, subarachnoid field is filled with, subarachnoid space is usually filled with CSF. So when you want to, for example, when you're doing examination, you want to get CSF for examination. For example, when you suspect somebody has meningitis, sometimes you want to take a sample of spinal fluid or CSF, cerebrospinal fluid, for investigation within the lab to rule out meningitis, infection, or anything else. So this is where you can imagine where if you are to put a spinal needle through the back to get this, you do it around maybe L4, L3, L4 level. You have to make sure so that you don't injure the spinal cord. Because if you are to put a needle maybe at L1 or T12, then you are likely to injure the spinal cord. But if you put it at L3, L4, you are well below the spinal cord. You will not be able to injure these nerves because they are very small and thin nerves. You will not be able, all the needle will do is just to push them aside, and then you are able to get the fluid and then be able to aspirate it for the purposes of investigation. So when you go to the clinical area, one of the things you probably will be able to learn to do is what we call lumbar puncture. So you are putting the needle into this lumbar cistern to get CSF for investigation. So you can see filum terminale, it goes all the way to the sacrum, but you see where this lumbar cistern ends. So it ends at around S2. So it doesn't go all the way to it's only filum terminale continues all the way. So filum terminale, prolongation of the pia mater from the apex of the conus medullaris, descend to be attached to the back of the coccyx. That is the spine. You can see the various nerves. As we are saying that the cervical region, we have seven cervical vertebra, but we have 8 cervical nerves. And then thoracic region, we have 12 thoracic nerves, T1 to T12. Then the lumbar region, we have 5 nerves, lumbar nerves, L1 to L5. Then the sacral region, we have 5 sacral nerves, S1 to S5. And then the coccyx, we have only 1 nerve. So we have only 1 nerve, CX1. Yeah, basically that is, and that's another. So we end there. It's been a lot. Unfortunately, we have to continue because I think on Friday, on Thursday, we should be able to finish. So we have to bear with me. I think it will not be too bad. You guys can bear. So we should be done by 10. So we'll have to move on to the special senses. And then we'll be done. This should be quite short. Yeah. So we are moving on to the special senses. Remember here we see it's not the 5 common senses because the 5th one is basically touch, basically the skin. If you touch anywhere in the skin, then that's a sense of touch. So they don't have special organ really there, but just the skin. So basically we are going to look shortly about hearing and balance, the sight, smell, and taste. So of course, when you talk about hearing, you're looking at mainly the ear. Of course, in physiology, hopefully you'll be taught about now the process of now being able to hear. But here for us, we are looking at the anatomy. So what you can see from outside as part of the ear, mainly made of cartilage, that we had talked the last time about, is the auricle or the pinna. The outside, the part that, and of course, it's thought that it's supposed to just gather, sound waves and be able to direct it into the external auditory canal. That is, so we have the external ear from the auricle to the eardrum. That's what we call the external ear, or to the tympanic membrane, the eardrum. Then from the eardrum to the oval window, that's called the middle ear. And then from after that, we have the inner ear. So the ear is the outer ear, the middle ear, the inner ear. So in the outer ear, we have the auricle or the pinna, and then we have the external auditory canal. And we know that the epithelium of the external auditory canal, usually they have some glands that produce wax, your earwax. Cerumen, I think this will be called cerumen, the earwax. And usually, of course, it should be able to, usually the body is just a way of preventing dust or other things from getting into the ear. It's supposed to be able to trap it and it flows out. Usually, we don't have to keep cleaning. I see a lot of people like using earbuds. Usually, it's very dangerous because you will be impacting that wax. And we've seen people who have used earbuds until they've impacted wax, until they can't hear because it's just full of wax. Usually wax will flow out by itself. As you bathe, it will come out and so on. So you don't have to put earbuds into your ears. Yeah, as in it really may cause more problem. And then of course, at the end of it, you have the eardrum or tympanic membrane that now the sounds are supposed to vibrate it. And then you go to the middle ear where you have now those ossicles, those small bones, we call them ossicles. We have malleus, so it looks like a hammer, the incus, and then we have the stapes. It look like a stirrup. When you go to the hospital, you'll be able to see what we say are stirrups. Yeah, so those ones transmit sound, are supposed to transmit sound to the oval window. And then now from there, the sound is supposed to go to the ear, inner ear, where we have the semicircular canal, the cochlea, and then we have the nerve, vestibulocochlear, that now carries that sensation or the hearing all the way to the auditory cortex, a place that are concerned with discerning sounds. And then you can see, more importantly, you can see a connection between the middle ear and the pharynx that we have talked about, the auditory or eustachian tube. Yeah, and usually this one helps control the pressure between the middle ear and the outer ear. So it helps control that pressure of the tympanic membrane. It actually equalizes the pressure for you to be able to hear better. And then sometimes if you have infection within the middle ear, we call it otitis media. You can have chronic otitis media or acute otitis media. And sometimes you've seen people with pus coming out of their ears. So most of the time it means there's accumulation of pus there, and probably the auditory eustachian tube have been blocked for some reason. And then there is perforation of the tympanic membrane. And so you end up with pus coming out of the perforated tympanic membrane. So you end up with that pus coming out of somebody's ear. So basically that is chronic otitis media. And of course it can cause, if it is not well controlled and treated, it can lead to deafness. Yeah, so that is the ear basically. And I believe in physiology, you should probably be able to be taught how the hearing process takes place. So for us, that is the anatomy. And then the eye, very importantly, which give us the sense of sight, so we are able to see. So we're looking at the structure of the eye. So you can see the eyeball there. And the wall of the eyeball, you can see the sclera. That is mostly the white part. If you look at your eye, the white part, the lower part, when you can see the white, that is the sclera. And then we have the choroid. Choroid mostly will be chocolate colored. And usually this one is supposed to absorb light. Once light has gone in, it's supposed to be able to absorb it. And then the inner part is the retina. That is the light sensitive part of your eye, behind the posterior part of your eye. And then you can see, if you look down there, you can see a place that seems to be some depression there. That is called the fovea. That is that area of the retina. That is where there is a very high concentration of cones. Usually the retina has two types of cells. There is the cones and the rods. Rods mostly that the one that you will use in scenario where there is low light intensity. And then the rods, mostly where there is a lot of light and mostly sensitive also to color. So color vision, the rods, the cones. And then you can see the optic nerve. And then, of course, you can see the blood vessels. Yeah, you can see the blood vessels. And, of course, anteriorly, that is in the front of the eye, we have the cornea. Cornea is the transparent part of your eye. And importantly, you need to know that a cornea, actually, you can do corneal transplant. You can transplant a cornea. So that is why one of the things that if somebody is a donor of organs, you are advised to donate your cornea. So, of course, we don't want people to die, but once you die, you can donate it. It can be removed and stored so that it can be given to other people. Because sometimes people develop corneal opacity. Their cornea become opaque, but it become white so that they cannot be able to see well because light cannot pass through it. So usually the cornea is supposed to, it doesn't have blood vessels. The cornea should not have blood vessels. It's avascular and should be transparent to allow light to go through. And then you can see the lens. Yeah. And then you can see the iris, those two, that actually surrounding it. That is what creates the pupil. Yeah, so the iris, those muscles around it is what create the pupil where light goes through. And then in front there, we have the anterior chamber. And behind the iris, we have what we call posterior chamber. And mostly in the anterior chamber, we have what we call aqueous humor. It's more of watery-like fluid. And then posteriorly, that is between the lens and the retina, we have what we call vitreous humor. It's jelly-like, clear substance. It's gel-like, it's almost like a gel. Yeah, vitreous humor. And then in front there we have the aqueous humor. That is after the cornea. We have fluid filling there called aqueous humor. So more details on the eye. You can see the lens. Zonular fibers basically connect to the ciliary muscle. So you can imagine when this muscle contract, usually when they contract, when the ciliary muscle contract, the zonular fibers tend to actually contract and fool the lens, and so makes the lens more thinner. And then when it relaxes, the lens becomes wider or bigger. It becomes more globular. And then you can see the iris. So the iris on this side, the other iris, between the iris now is we have that aperture that we call the pupil. Basically that opening that now connects with the lens. And these iris are the pupil is the one that responds to light. When there's a lot of light, it tends to constrict and makes the pupil narrower. And then, of course, when there is less light, it tends to open up so that to allow more light to get in. Yeah, so you can see the anterior chamber where we have the aqueous humor and so on. So, of course, one of the things that can affect the eye, there is something called glaucoma. Because this fluid, especially the anterior chamber, should be able to flow. You can see this canal there. It should be able to flow freely. So you can imagine if you block those canals, then you'll have increased pressure within the anterior chamber. That is what basically we call glaucoma. And one of the causes of glaucoma can be infection. Yeah, just infection of the eyes can end up blocking. Of course, there are other causes of glaucoma, and there are different types of glaucoma that you will probably learn when you go to your clinical area. So more on the eye, you can see the retina. You can see where I talked about the fovea centralis. That is where mainly there is high concentration. Actually, at the fovea centralis, there you don't only find cones. Yeah, as I said, there is cones and then there is rods. Cones is CONES. Then the rod is RODS. Basically, those are types of cells that are sensitive to light and that enable us to be able actually to see, interpret images, and so on. So at the fovea centralis, that is where it will be whatever. If the image falls there, then it will be very clear, because that is where mainly the cones are there, and they're sensitive to light and color. So that is the point where the vision is best. And you can see the blood vessels should not come all the way there. Yeah, because if blood vessels grow there, then you will have problem. You can actually end up with blindness. For some diseases, like if you have a diabetes that is not well controlled, sometimes there is proliferation of blood vessels. And so you end up with blood vessels growing all the way, even to the fovea. And so you may end up actually, somebody end up becoming blind. And then you can see the optic disc. That is basically, there's blood vessels, and then there is the optic nerve. Then, of course, there are blood vessels and so on that we see there. That is the retina. Of course, another condition that can affect the retina, we can have what we call retinal detachment. That the retina can detach from, we have talked about, when you look at it can detach from the choroid. So if you have the retina detaching from the choroid, then you have what we call retinal detachment. And of course, somebody will end up being blind if there is that detachment. Yeah, and then of course there is a system of the lacrimal duct, that is the tearing, because tears are very important for our bodies, for our eyes. It is able to actually give, for example, as I had said about the cornea, it is avascular, so it should be able to bring oxygen, the fluid, and so on, and even lubricate it so that you prevent your eyes from becoming dry. That is why you always are blinking. That is spreading that, that tears all over your eyes. Of course, the tears you only see if it is in situation of excess emotional situation where you are producing excessive tears. But always there are tears that are supposed to moisten our eyes and prevent drying. So you can see, if you are to look at it from anterior, you see the iris, which basically that muscle. Then the pupil is basically that space between the iris. You can see the iris has, the muscles are arranged mostly in a radial way, so that if you are having contraction, you end up with either narrowing of the pupil or dilation, opening up of the pupil. Of course, it's one of the things that we look when we are examining patients. Put some light or some light on the eyes, so you see whether the pupils are reacting to light or not. Sometimes, for example, one of the things when you examine when somebody is dead, usually the pupil tend to dilate. That basically the iris, it is completely dilated and is not reactive to light. So that is one of the signs that somebody could be dead. The pupils are completely dilated and are not reactive to light. Usually when you shine light there, it should be able to constrict. So you can see there is the lacrimal gland or the tear gland, and then they are opening that open into the eye. And then you can see the way it flows. So from there, it goes medially. This other side where there is a nasolacrimal duct that is connecting it to the nose. This is the medial side, and that is the lateral side. And you see how it flows. So there are those lacrimal canaliculi. So it should flow in that direction. And that is why sometimes when somebody is in a lot of emotional situation, they cry a lot, they end up having to sneeze every time you hear them, like they're sneezing now, because that basically excessive tears is going into the nose. Yeah, and that is why, that is the reason. That is basically another diagram showing the lacrimal duct, the way the tears will flow. So if they're excessive, is now when you see somebody crying, the tears pouring all over from the lower lid and so on. And even into the nose, there'll be excessive tears there. So following that, so if you block, of course, if for some reason any of those ducts are blocked, you know, those lacrimal ducts are blocked, then you'll end up with a mass, because that lacrimal duct will be filled with fluid, and so you'll end up with a cyst. So of course, if you block any of these others that are supposed to drain the tears, then you'll end up with excessive tearing, because the drain, the canaliculus may be blocked, and so you end up with excessive tearing. Yeah, and that is why when you have infection in your eyes or something, sometimes a lot of tears are produced, and then you have a lot of just tearing generally. So that system, those apparatus are important, and they have to remain open. So that is lacrimal fluid, watery saline. So it's more of salty, like if you are to test it. I'm sure some of you have cried and tested your tears. It tends to be salty. Let's talk of saline, and it is physiological, and it contains some enzymes. So it's bactericidal. So it kills enzymes, so bacteria. So it's important, and also it moistens the conjunctiva and the cornea so that you don't become dry. You don't have dry eyes, and also provide nutrient and detox oxygen to the cornea. As I said, cornea is avascular. It doesn't have blood vessels. That is why it should be clear. If it develops blood vessels, then you end up with blindness. Extraocular muscles, you look at them, we have talked about cranial nerves and the one they supply. So you can see those extraocular muscles. Those are the muscles that control the eyeball. So you are able to move your eye. You're looking to the left, to the right, up, down. It's because of this movement, and you know the nerves that supply them. Then we have accessory organs of the eye. For example, the eyebrows, the eyelashes. Those are basically most of the time just to protect the eye. For example, the eyebrows are supposed to trap some dust and so on. Maybe if there's a lot of water, sweating and so on, it doesn't flow directly into the eye. It's supposed to protect it. And also, of course, the eyelashes, supposed to protect the eye from things getting in. Yeah, of course, some people, of course, sometimes they enhance those, you know, those eyelashes. They put false eyelashes. Those people want to make the eyelashes appear big. They almost appear like windshield, you know, of a car. So especially the ladies, sometimes they want to enhance their eyelashes by adding, you know, those false ones. So all those are supposed to protect the eye. So the accessory, the eyebrows, the eyelashes, and even, of course, these lacrimal ducts, they give, they're able to moisten the eye. And of course, the lacrimal sac and so on, they're draining. They help drain. So it goes all the way to the nose and so on. Yeah, then the sense of smell, of olfaction. So the nose, you can see there is what we call turbinates, and sometimes they can become hypertrophied and can cause blockage of the nose. Yeah, if they become inflamed and then they become enlarged and so on. And then you can see where the olfactory bulb is. That is where the nerve, olfactory nerve will be. And that mucosa and the upper part of the nose is where the nerves are, the nerve endings of the olfaction. That is basically the sense of smell. And so it helps us. And of course, these turbinates also help increase the surface area for the smell that come in to be dissolved around there, and for you to better be able to sense it. Noteworthy is the fact that a sense of smell is one of those smells that really acclimatize so fast. So that if you are taken to a place where there is a bad smell, if you stay there for a few minutes, you actually don't feel that smell anymore because you've acclimatized. Yeah, so these turbinates increase surface area for the purposes of being able to smell. And of course, you know the nose is divided into two. There is the nososeptum, what we call nososeptum, basically made of cartilage. It's made of cartilage. So I think, and of course, there is a relationship between the sense of smell and sometimes taste. Yeah, sometimes you realize that if you have a cold, you know, flu and cold, sometimes even taste changes sometimes. Yeah, because smell and taste sometimes seem to have to be actually related. Yeah, and of course, you know, in our nose, there are some hairs. If you look at many noses and the inside, there's some hair. All those are supposed to trap, you know, foreign things that are entering the nose. And even there is mucus also. They're supposed to trap dust and so on. All of them are just to try and prevent, you know, foreign things or bodies, dust and so on from getting all the way into our lungs. because this is mostly the nose is where you use for respiration, is breathing in and out. You usually use the nose. Of course, there are some people you can still breathe through the nose, through the mouth. If your nose is blocked, you can still breathe through the mouth. But that is not the ideal, because the mouth does not have all these things. It doesn't have mucus to trap dust and so on. So usually the best place to breathe through is your nose, because it has all those modification. That is, there's olfaction. You can see the olfactory mucosa and so on. So I think you look at it at your own time. Then there is the taste, sense of taste. As we are there are many nerves that contribute to this: glossopharyngeal, even part of vagus, facial nerve. Yeah, the anterior part of the tongue especially, mostly will be the facial nerve. And of course, some other books, if you go to physiology, they talk of the front part of the tongue, maybe for sweet things, but really, in real life, it's not really very important. It may not even be true that the tongue is divided into various areas for testing different kinds of tests. In physiology, will be taught about different tests, sweet, and so on. The other tests, salty, and many other tests. So, of course, the main thing that we use for testing is the test buds. Yeah, and it is all over our tongue, test buds. There are different types. There are what you call papilla, and the posterior, there is, for example, the lingual tonsil there. You can see the valid papilla, fungiform papilla, fusiform papilla. All those are basically places where you will find the test buds. Yeah, and you can see the diagram of a test bud there. So usually for you to be able to test, usually whatever it is that you're taking, it should dissolve in saliva and so on, and so that it can be able to have, you're able to have that sense of taste. And we thank God, of course, for that sense of taste, that we are actually, if you don't eat, you're likely to die. So God gave us taste buds so that we can actually enjoy food that we require for our survival. Yeah, so that is a diagram of a test bud. Yeah, I'll not go into a lot of details, so you will go read for yourself, look at more details on the same test bud. Of course, some of the conditions that can affect the eye, quite common, cataract. Basically, cataract is opacification of the lens. So especially because in old age, and of course it can occur from other reasons. And sometimes the way to correct it, there's what we call cataract surgery, where you remove that lens and then you put an artificial one in its place. Of course, it will not be the best of sights, but at least it will enable somebody to be able to see. Yeah, so that lens is opacified. Of course, as I said, the cornea also can become opacified, it become white, and so light is not able to pass through as well as it should. So some of the conditions we've already mentioned, you can have otitis externa, is inflammation of the external ear. That is the external auditory meatus. You can have inflammation in it. You can have infection there. And then we can have otitis media, which can be chronic or acute. That is inflammation or infection within the middle ear, which sometimes it can become infected, even develop pus there. And somebody can have the eardrum opening up, and then you have pus coming out of the ears, otitis media. Of course, you can have deafness, you can have blindness, with many causes, cataract, myopia. So when you talk about myopia, basically it's short-sightedness. For example, myself, I wear specs, not because of, it's not swag or anything. I'm short-sighted, so I have what we call myopia. So myopia is short-sightedness. And in this case, they usually say the light tend to fall, they fall in front of, I think, the retina. And so the lenses that you use would be diverging lenses, that is concave lenses, diverted so that it can go directly, and the light usually should fall into the retina for you to be able to see clearly. Then hyperopia is long-sightedness. In this case, I think the light, they say it comes together behind the retina. So you need lenses that's supposed to refract light better. That is basically you use convex lenses, so that you're able to bring the light right at the retina so that you're able to see. So that is called hyperopia. That is long-sightedness, long sight. So somebody is long-sighted. So somebody who is long-sighted can see something that is far away clearly, but cannot see something that is near clearly. And somebody who is short-sighted can see something that is near well, but cannot see something far away properly. So they are corrected with the lenses that we are given in the spectacles. Then glaucoma, as already talked, basically glaucoma is increased intraocular pressure. So the pressure within the eye is increased because of blockage or flow of aqueous humor. Yeah, because of blockage. So you end up with increased intraocular pressure and can lead to blindness. Autosclerosis is those ossicles. Remember, there was the malleus, incus, and stapes. Sometimes for some people, it become hardened. Yeah, so it becomes fixed to one another. They're supposed to be moving. They're able to vibrate and allow transmission of sounds. But in this case, they become hardened. And then somebody end up with a hearing loss because of that. Tend to be inherited and tend to be common, especially maybe among sisters or female relatives. So it tends to be inherited for some reason, autosclerosis. Yeah, so we'll leave it there. Thank you so much. And Pauline, it really taken us a while, but it's okay. So thank you so much. I think we meet on Thursday for the last one. On Thursday we'll be talking about the back. So thank you all of you for attending. And sorry they've taken so long. Hopefully next time we begin early, we should be able to finish early. It's not very